So at this point, we're going to open it up. So we just want to do a quick review of the slides that John did online. And now it's kind of open for conversation, really to talk about challenges and maybe to explore some of the things that came up. And what do you see as kind of next steps? Yep.
John, certainly it's my experience, and I think it's been most of your experience, that we've been assessing individuals in terms of their achievement of certain educational goals, their competency to perform certain tasks, and so forth. As we've already mentioned this morning, a big focus of this forum is on interdisciplinary work and team function. Is it possible to apply these same principles to evaluating teams and to assess how well they are performing?
Yeah, excuse me, yes, absolutely, Jordy. I think the same principles obtain regardless of what the assessment situation is. But I think the challenges increase dramatically when you talk about teams. And I think that it is an area ripe for considerable research. But there's also been some work done around team assessment that I think is useful and a good start into the process. So I think all the work for around 360-degree assessment, for example, is a wonderful way to enter into the process of measuring teams. There's lots of good work done in simulation, especially among the pilots, but that's now translated into the health professions as well. So I think we're at the beginning, but I think that all these principles obtain, and I think that there's lots of work to be done, and it's a really exciting area from an assessment perspective. Yeah.
So this probably falls under the category of feasibility, but I'm interested in the activity cost of assessment versus other kinds of activities. Many of us manage both faculties and clinical systems. How much time should be spent in assessment as part of an overall teaching role? And how has that evolved in your observation?
Okay, that's a really good question. I guess part of my response is going to be another question, and that is, of course, when you get a hard question, you just throw it right back. Part of the question is how much of it is going to be focused on summative assessment, and how much is going to be focused on formative. I think when we think about assessment and the resources devoted to it, everybody gets excited thinking there's far too much devoted to assessment, and there might be far too much devoted to summative assessment. There certainly is not enough devoted to formative assessment, which is the piece that drives learning and the piece that's integrated with learning. So I think part of the response is that we could probably use a little bit, we could use to slim down a little bit how much time we're spending on summative assessment, spend a lot more on formative. The other thing I would say is, putting time aside for a moment, assessment is really, especially if you can collaborate with partners, across institutions, can be done relatively efficiently. Our institutions are not so good at sharing the ways they do assessment, so that everybody has to have their own examination. Every examination has to be tailored to your specific lecture, when they're vast commonalities that we don't take advantage of. So my answer, to summarize, goes back to how much is formative, how much is summative, probably a little too much summative. And I think if we were a little better at sharing resources across institutions, we could do a better job.
Spread the fixed costs across institutions.
That's exactly right. And it's all of assessment is, well, not all of it, but lots of what we do in terms of summative assessment is fixed cost. And the biggest costs are fixed costs, and the numbers go down dramatically as volumes go up.
And Warren, just if I could weigh in a little bit on that, I also think we have to think from a public perspective, and what's the return on investment when we don't do the assessment, that we put out people who are insufficiently prepared, and that actually carries a much higher cost. If you think about a 30-year career, then spending the time, particularly on the formative side, to make sure people are acquiring the competence they need to be effective. And I think we've lost sight of that. We always tend to think about the short term and time cost, not recognizing that not putting that effort in comes at a heavy cost over time. And I also think we haven't done a good job of thinking about how we embed assessment into the daily activities we're doing. Like those things called bedside rounds. That can be a form of observation and assessment, and we don't take advantage of enough of that. And a lot of the really good tools like multi-source are relatively low tech. They just involve a series of observations, and what we need to figure out is how do you capture them in a way that's sufficiently reliable and valid so you can make appropriate judgments and inferences.
Yeah.
At this meeting, we've really made it purposeful to include students and patients. And so frequently when we talk about IPE, we talk about all the different disciplines. However, we're really trying to say that the patients need to be a part of the team, families need to be part of the team, and students need to be a part of the team. So how would you talk about assessments? Because that word competency in this and that and the other and how we protect the public is one thing, but when we include the public, I'm just curious what your thoughts are about broadening it in the way that we're starting to see the team not just be the interprofessional providers.
Oh, I mean, if you go back to multi-source feedback and the use of patients in the assessment of healthcare providers, absolutely essential. Absolutely essential that they develop the tools that are being used to do that assessment, because it's the patient perspective that's important there. The patient perspective is not the only perspective, but it's an absolutely key perspective in that. I know in the UK, what they've done is they've started in some of their procedures for physicians who are in trouble to include a patient member of every panel, considering the issues involved in making judgments about those physicians. I think that's another excellent use of patients and other folks who are involved in the assessment process. So they need to be included as broadly within what their competence is as possible. I wouldn't have them write multiple choice questions, but I think there's a huge contribution that they can and should be making to this process. And the process will lack validity if they're not involved. Yeah.
I just wanted to follow. Do you have suggestions about how to incorporate that more actively in curricula? Because frequently the students are somewhat separated from patients and families.
I know of, not the specific reference, but I know of several groups who have worked very hard, and I know that they're working hard on this in the UK in terms of incorporating patients in the education of all healthcare providers. So the family and the team is being interviewed, students are exposed early on to feedback, and I can't think of the reference off the top of my head, but some good work, at least in the UK, probably elsewhere, I'm just not familiar with.
And John, the other thing that I think, Patricia, that's been really at least promising is these longitudinal integrated clerkships, where students are basically assigned a group of patients and family that they will follow longitudinally over all 4 years, and that those folks play a major role in the assessment and feedback to the students. They're resource intensive, but some of the preliminary data coming out of Harvard, like David Hirsch's work, also in Canada and Australia, is promising. The question is how to resource it. The Commonwealth Medical School in Scranton is actually moved to an entirely LIC-based model. So every student at Commonwealth will basically be in an LIC-type model for their entire medical education. So we'll see.
Yeah.
This is directed, I think, both to Eric and to John. Eric, I remember at a different meeting, you made a reference to high stakes evaluation and some of the challenges that presents. And so I think it's really, especially from the summative assessment perspective, important to understand what you're thinking about that.
Well, John actually is much more qualified, so I'll turn to him in a minute. I think John's got it right when it's more about balance. I do think that some element of summative assessment's important. It's part of our public accountability. So, I work at the American Board of Internal Medicine, and the certification exam to me is part of that public accountability. We also know, literally through decades of work now, much of it done by John, so I should be the one talking, that it does, correlate with how they go out and perform, that, knowledge matters, that you can't have an empty hard drive, right? It's the same thing with team. You can't put a bunch of Homer Simpsons on the team and expect the team to function, right? And so I think that's the tension, and I do think there's value to that. Obviously, I'm biased, Frankly, I also see something like the high stakes stuff as, in addition to public accountability, it's an act of professionalism. It's my willingness to show that I have sufficient knowledge, and not only that I just have recall, but I can use that knowledge. The tests actually are pretty sophisticated. They do get at some of the reasoning skills. It's not just like, can you remember what the 5 causes of, whatever is. You have to integrate facts to pass those exams. I think the problem is I think our balance is off, and so people wait. What I tend to see is like, well, the certification exam will take care of that. They don't do all the formative stuff that John just talked about. It's really depressing to me that, 13 years into the Outcomes Project, the amount of direct observation our program directors tell us they're doing of their residents is incredibly small. It's few in number. In fact, on average, it's less than 4 per year. All right, they're willing to tell us that on the tracking form. So I think that's part of the problem. John, I would love your thoughts on that.
No, I think Eric covered it. I think summative assessment is absolutely essential. I think it is an abdication of the responsibility of a profession not to have some form of summative examination. And I'll push even further and say that it ought to be a national examination at the end of training. I think there's good evidence that there's a relationship between that and patient outcomes, and I think it is, from that perspective, essential. Same time, as Eric said, it's absolutely critical that schools, institutions involved with the education of folks do their job. And their job is to do formative assessment, as well as some summative assessment, but mainly formative assessment in order to ensure that the trainees are prepared when they get to the point to take the examination and take care of patients.
And just one more thing, just to build on that. I mean, the irony is if you really do the formative assessment well, and it's continuous and longitudinal, the summative decisions actually become easier. And at the end of the day, at least in residency training, I can tell you the final summative evaluation is the judgment of the program to graduate somebody or not. That's a summative assessment. That's what determines whether or not, at least in my field, you go out and practice. It's not the certification exam. You pass a licensing exam, if you're graduated, that is a summative decision. You go out and practice. We know, though, if you don't pass the certification exam, guess who you end up taking care of? You don't go to suburban areas, you end up taking more of the disadvantage. So the irony is we in certification exacerbate disparities. We don't make them better. And so that's why the formative assessment is so important, because if somebody really shouldn't get to that stage, that is dealt with much earlier than waiting till the end when you got to make a judgment and then sometimes the right decision isn't made.
Yes.
I just wanted to ask about the assessments we're talking about is the outcome is to produce better doctors or healthier people, because I'm sure that we all would say that you all are good doctors. I'm not a medical doctor. I'm a social work student, and I'm sure you all will say you all are good doctors. But still, we have obese people, and we have people with high blood pressure. My understanding is that the doctors are surprised that people are still with high blood pressure. So how do we put into the assessment the goal of having healthier people? I'm not sure. I just don't know.
Do you want to?
Well, I'll start in the turn of the video. I think your point's a really good one. I mean, it doesn't matter if you're, I would argue this is even important for social work, right? This is all of us in the health professions. No. Because I think that part of what I like about the competency-based movement and what this group actually had the opportunity here was from Julio Frank, is that our educational systems outcomes ought to be focused on what the health and health system needs are, right? And so I think using the triple aim is actually a good marker. Our education systems ought to be moving toward better health care at lower cost, right? That ought to be our goal. Obviously, we're a component of that, but I think our curriculum and assessments ought to be designed to figure out how do we help achieve that goal. And it's not just docs; it's everybody. I mean, you as a social worker, through your communication and support services, are huge to accomplishing that. And I think in many respects, it's the stuff outside the physician's office that's more important about health, to be frank. And so it's a component, but I think that is the eye we want to keep all our programs on.
And if you take that down to a sort of lower level in terms of actually putting together individual assessments, it's absolutely critical that those assessments reflect the domain to which you want the assessment to be relevant. So if your goal when you're putting together a test is to make sure that these folks can take care of patients well, you look not to the curriculum for the content, you look to the practice. So when you put together a licensing or certifying exam, some national examination, sort of regardless of the discipline, you're not looking back at you shouldn't be looking back at the curriculum. Lots of people do that, and it's the wrong way around it. You really need to look at practice and figure out what's going on in practice.
In IPE, that education sector, in addition to our own disciplines, we do, I think, probably a decent job assessing through multiple choice tests, skills checklists, and clinical education and all that. But the challenge is taking that, translating that over into practice and trying to, can they implement and perform those competencies over in practice, and how do you measure that? Because now you have patients involved, and even to add more value on what we're doing with education into the practice arena. There's a big gap there. In fact, it wasn't a few years ago, a nurse executive advisory group they asked managers, how well are the graduates prepared when they come into practice? 11% said they were prepared. In the academic sector, 90% of the academics said they were prepared. So there's a huge practice academic gap, 90%, 10%. So we're having difficulty. We think they are prepared, we can assess, yeah, when you translate that into practice, they really aren't. What are your thoughts about that? And this is big for interprofessional education and practice.
Yeah, so my guess is that the place they would learn that is as part of their clinical training. And so as a consequence, I think it's absolutely critical, as Eric observed a little bit ago, that we move assessment from the classroom into that workplace-based setting. So there are a whole sort of set of assessments that fit in that context that I think might be useful, mostly formative, and that would be useful in helping that transition into the practice arena.
I just wanted to add one piece that I think would be useful for us to think about is how assessment is a catalyst for change for our programs, for the curriculum, for the education. Because right now we're talking about assessment of the learner and are they getting it and how, but it really, we should also be looking at how we can change our programs, designing, incremental assessment so that it's supportive of the learning.
And just one more thing I'll add to that. I think the other piece that we haven't paid enough attention to is where you embed people for their clinical training matters. If they're working in units that are dysfunctional or they're not experiencing the best care, guess what? They're not going to go out sufficiently prepared. And a lot of people have talked about that. And I think David Ash's article about what happens depending where you train in OB and then what happens when you go in practice is kind of sobering. And we're seeing some similar data at the board. So we can't lose sight of the fact that assessment has to be in the context of actually experiencing high quality interprofessional care. And if they're not, it's not a big surprise they go out and the people say, these people aren't prepared to do what we need them to do.
I believe clinical simulations can help bridge that gap when you insert teams and do team-based training and replicate that clinical activity, so then we can get feedback. The evidence shows us on the debriefing. Once we see how they perform and what they are doing or not doing, that's so valuable. So I just wanted to insert, I think it's exploding in that area.
Absolutely, good point. Yes.
Yes, I think it's also, we need to consider the context of what's happening in higher education. For example, if you take a look at what's happening with teacher education and K through 12 education, there now is being incorporated in the accreditation of teacher education outcome measures related to not just whether somebody can teach well, but whether the students learn. And that getting ready for practice is one thing. Whether your patients get well is another outcome measure. And I'm not sure that that's not going to be on the horizon in terms of society's expectation of the outcome of our programs, that we might at some point need to be assessing the outcome of the patient care that is offered by our students. And we haven't really talked about that, but I think it's really on the horizon for us, and we need to pay attention to it.
Oh, I think we're already there. I think academic medical centers and teaching centers are being held accountable for the quality care that comes out, and I think it's no longer acceptable to say like, well, they're in a teaching setting, things are going to happen, mistakes are going to get made, No, I mean, I think that's over. And in fact, what I found very interesting
At
in the
the group
IOM
level.
report, yeah, well, I think,
It's more at the
again,
group
it's
level.
complicated, but I do think that there's much more scrutiny now than what I've seen in a long time.
Hi, I just wanted to ask about, I think it's related to the issues that have come up, is both assessing the assessor, who is doing, what are the competencies, and how do you prepare the assessor to actually be able to judge, particularly when it comes to
Yes.
communication skills, bedside manners, and so.
Yeah, no, there's no question about it. Faculty development is an absolutely huge need in this area. People don't come out of their professional backgrounds knowing how to be teachers and assessors. There are, I think, a number of models around actually do that in a relatively efficient way, but you're right, that's absolutely essential. Carol?
Let me continue the faculty development stream and the importance of where you embed people in clinical training. I think one of the things many professions deal with right now is they have faculty who are providing formative feedback, but against the old model.
Yeah.
And too few faculty who are in the new model themselves. And I think we have many of us are experiencing a real shortage of clinical practices future-focused in which to embed the learners. So what have you seen, John, in terms of strategies that really can help assess the state of the clinical site, and how do you move them forward? How, could you use assessment really to help move the faculty forward?
You want to?
Well, Kara, I think there's a couple things to start. I mean, we're getting better at measuring practice characteristics. I mean, they're far from perfect, but I think the patient-centered medical home movement, those tools are slowly getting better. And I think that's a reasonable place to start. For example, the NCQA PCMH tool looks mostly at structure and process. They're beginning to embed outcomes into that tool, but I think that's a good place to start. The other set of tools is the Dartmouth microsystems work. We know there's a set of success characteristics associated with high functioning practices, and that tool exists and it's been used. So I do think those are just two examples. There's also idealized office design by HI. We just haven't really incorporated those into our academic environments as if they're important to education, right? They tend to be kind of separated instead of figuring out how do you integrate those sorts of quality criteria into an educational space. The other problem, particularly at least in our fields and residencies, particularly true in primary care residencies, they take care of a disproportionate amount of underserved patients in very resource-poor environments. And I think that's part of our challenge, and that's part of the investment moving forward is how do you do that? And some are doing it well, but it's been a huge struggle. I'm not be interested to hear about some of the other fields. But I think there are tools out there that can help, but a lot of our faculty, getting back to faculty, aren't aware of things. We weren't taught to do that. That's not the environment in which we train, and so there just isn't that knowledge quite out there as broadly as we'd like.
Yeah.
So faculty are thinking a lot about diversity and inclusiveness and how to design culturally competent kinds of assessments, because the learners are very different in the way they learn, but it's also our learners are saying to us we are also very different in how we should be assessed in terms of delivering whether, the benchmarks. So I'd like to hear your thoughts about gender differences and cultural differences, and how do we design assessments that with benchmarks, but that takes that into consideration. That's one part of my question. But the second is also related to, you mentioned Julio Frank and the Lancet report. And one of the things that happened after we published that report is that students challenged us and said what's missing there is the social mission. You haven't really addressed the social mission for nurses, physicians, and public health people. So how do you also assess our graduates in terms of a social mission? And I'd like to hear your thoughts on those two things.
Yeah, you're looking at me, aren't you? Yeah.
Well, I mean, I think your points are well taken. We have to figure out how we're going to use technology more effectively. It is interesting that for all the buzz around different learning styles. Turns out that's not as true as we actually think it is. I mean, there's been some interesting work published recently in Science and a few other stuff that, you know what, even our generation today, the ideas of all kinds of different learning styles, probably we've overstated that. I think as far as a social accountability professionalism, that has probably more to do with what they experience than what we assess. If they're not experiencing it, guess what? You can assess it all you want. I mean, I think Fred Hafferty's brilliant work on the hidden curriculum really holds here, and that we know those are profound influencers. So they have to experience it. It's nice to see it coming back in. Ironically, at least in where I've seen it, most of the drivers are in fact the students themselves. They're now driving more of the social accountability. And 2014, by the way, is an interesting year. It's the 50th anniversary of the modern version of the Hippocratic Oath, written by Louis Lasagna. And so it's interesting that there'll be for those who are interested, a whole series of articles of medical education come December and January. And the social accountability piece has come back, and also this concept of civic professionalism is also finding its way back. And I think but it's incumbent upon us to create environments that actually embrace and demonstrate those activities.
And the cultural issues, I think, in terms of assessment of individuals are absolutely critical. I think that it is absolutely essential that we scrutinize the methods we're using as well as the results of those to ensure that we're not disadvantaging anyone for cultural reasons. And there's a whole body of work around how to do that kind of that kind of assessment. But it's absolutely critical in a multicultural kind of setting. Excuse me? It needs to go up there. Okay, you've got number 8. You and I were going to write an article. That's beautiful. Yes.
So I'm John Finnegan. I'm with the ASPPH and Public Health. And I want to make a point here, and this is in relationship to what you were asking about. And I think it's important to recognize that competence in interpersonal communication, which is the base of patient-provider interaction, doesn't simply scale up to competency at the group level or competency at the social level or the cultural level. And so part of the discussion that we had last evening was about interprofessional education and what are some of the expectations that we have of the next generation of training. And leadership keeps coming to the foreground as a key part of this. And yet when you begin to sort of deconstruct, well, what does that mean? You really get down into a whole set of communication-based competencies that have to do with fluency in a variety of areas of communication, including strategic communication and so forth, that seem to play a major role in that leadership. This is not the charismatic leader that has all the answers and everyone wants to follow. This is about the creation of consensual visions and operations that would come out of that in order to make them real. Fortunately, you don't have to reinvent the wheel or invent a new wheel even. There are an enormous number of competencies that are already out there, can already be evaluated at these different levels. And that includes something known as sociolinguistic competency, which includes the cultural rules, shall we say, of different communities and different cultures. And there are ways that those can be extracted and tested as well. So I throw that out there because I think that although, we certainly, interpersonal communication in the clinical setting is enormously important, and you want that to be good, it's not the same as communication in teams, and it's not the same as communication at a larger system level, and it's not the same as communication at a social level where you're trying to essentially create change or catalyze change. So, but as I say, with communication sciences, you've got a whole bunch of competencies at different levels that could, from which you could extract those things.
Beverly Malone with the National League for Nursing, and I've been thinking about assessment and what a joy it is not to be assessed as a faculty member because I'm teaching by myself, and yet interprofessional may mean that I'm teaching with someone else. And I was wondering about formative assessment and summative assessment in terms of the peer assessment.
Yes.
And the challenge around that and what your thoughts were around it, because talking about moving to a different level, peer assessment is going to be a real interesting challenge.
Absolutely, absolutely. So in addition to the fact that there's no faculty development that we're doing, we're not doing much assessment of the people who are teaching either. And there are sort of developing now a set of measures for teachers, peer assessment being among them. Peer assessment clearly has some challenges, but I think there's good evidence that properly done, it's a wonderful addition to the other ways that the teachers are going to be assessed. One of the ways, by the way, will be outcomes, as you mentioned. The outcomes of students are another way to assess teachers. So there's a roster of 10 or 15 or 20 ways to do this, but we're just at the beginning phases of actually employing that and using it in some way. Yeah.
Going back to Darla's point about how we might look at program and curriculum and assessment, I think all of us in here are, I mean, I'll speak for myself and others that I'm hearing, I think we sometimes see it in a parallel universe. It's sort of how would I assess nursing, how would I assess medicine, how would I assess in that kind of way. So from our international partners, what we've seen is where they've brought a common core curriculum and they've educated all of the healthcare professionals with common content together and common expectations and then branched off or moved forward. I wonder if you could really talk about how we might think about assessment differently, not so much just in the area of what does a physician need to know, what does a social worker need to know, and it gets back to a little bit the social accountability, but there's more there that I think we need to think about outside the box. You know, otherwise we put them out there and they've been already ingrained by assessment that they are one of a kind of this kind of person or professional.
Do you want to? Okay. It seems like the initial issue is not assessment, it's training. There has to be some training spot where that occurs. You can't assess what doesn't exist. Okay, so the first step is that if there's some sort of educational process in place that allows those interprofessional skills to develop, then putting assessment as a piece of that or incorporating it is, I actually think, reasonably straightforward. There aren't great methods around, but there are very reasonable ways to do assessment in the context of work. So it's a matter of getting the clinical training right, and the assessment piece will follow along.
Yeah, I think we're fortunate we'll hear tomorrow from our international collaborators who are actually doing some of this, but I think part of the problem, Patricia, is that at least partly what I've seen is we create these kind of brief experiences, or what anthropologists call a tourist experience, and then we expect somehow that people are going to pick up skills, and then if we assess against that, and I think it's what John said, and I think that's what we've also learned from international partners. I think one of the things I would challenge all of us is to think about how can this group catalyze more of that? You know, there's a lot of wonderful, wisdom, but also leadership sitting in the room. How do we begin to move that, and how can we facilitate? Because essentially this is catalytic and a facilitating event, right? So how can we take that back and connect those together, I think is a really important question for us over the next day and a half.
And that's the reason I asked the question, because if we don't start saying that this is an important competency that we're going to assess, that forces down how we rethink curriculum, we're not going to. Yeah.
Yes.
So from the patient's perspective, their encounter with their clinician or provider is sort of a one-time and often very personal feeling and particular event. So I'm wondering what the methodologies and challenges are for equivalence when you're incorporating the patient's very particular set of experiences.
You hit the nail right on the head. There is a serious issue there. Obviously, if you look at the literature on patient assessments of their physicians, it varies by age, it varies by severity of illness, sort of regardless of what the physician does. That said, given those factors, some of which are biasing, there's a truth in the center of that. That reflects both the patient but also the provider. And so the only way I know to do this, given all these things, is to sample as broadly as possible so that as a physician or as a nurse or as anybody, we're evaluated on a number of different occasions by as many different people as we possibly can, because that will, to some degree, mitigate those biasing factors. Won't ever make them go away. The second thing I would say, at least, and I don't know about outside medicine, but at least for physicians, patients express considerable love for their doctors. It's relatively rare that a patient will have several patients have a concern about the same doctor. So the other side of that is that the methods that we're talking about, where you incorporate patient input, is that if you find a doctor or another provider who's bad, they're really bad. Okay, so it seems to me like there are the two pieces. The third piece is that if you can get patients to spend the time to provide specific feedback about their provider, that feedback is good formative assessment. So there are 2 or 3 good reasons to include patients. One is that if they identify somebody who's really bad, they're really bad, and they're a problem. Second is that there are ways to provide information that compares a physician or a nurse or anybody else with their colleagues, their peers. And third, if you do the assessment properly and you can get individual input and feedback to the provider, it makes a huge difference in their performance.
I think we have time for one more question, and then we'll take a break. That's all hands up? Yep.
So one of the things we've been pondering as time to do formative assessment has become very limited in clinical medicine is how we can do 60-second formative assessments. But also thinking about it in a way that it becomes part of the learner and our own lifelong goal to have continuing formative assessment. So the example I would give is in the OR. We end every case with what went well, and the whole team responds. What didn't go so well, and the whole team responds, and it includes things like, I didn't use my passer correctly. I didn't think to have something in both hands, whatever we're working on at that developmental stage. Or nursing might have a set of things that we didn't think of ahead of time. But what I observe is that over time, even though a small number of us started it, everybody is starting to use it, and they expect it. So I'm wondering if there are other examples or other ways we can use our 60-second focus to really get feedback from patients, because obviously in the OR at that time, they're really not awake to share with us. But ideas that you have would be welcome.
Well, I just want to highlight a couple things there. One, you're embedding formative assessment into the work that you do. I think that's really important. And I think we have to be careful not to use time as an excuse. I realize things are chaotic, but as I mentioned earlier, it's a return on investment. I actually see it as a professional obligation to assess. It's part of our educational professionalism, and I don't think we should lose sight of that. But I think you're right. There's lots of ways to take advantage of 2 to 3 minutes of observation that can be very rich in detail. And I think that's, we just have to look for more of those opportunities. And you're right, once you start to make it a habit, people just pick up on it and you build it into the system. That's been my experience too, that once you start it and you role model it and you make it, kind of part of the activity, then, people come to expect it. It actually helps drive culture change. And I think we can't lose sight of that as well, that the way we do our work and the way we assess will affect the culture, to help to change things. So one more from Jordy, and then we'll take our break.
This last comment just brought to mind the notion of reflection and self-assessment. And I just wondered, it seems to me a rich possibility for tapping into that sort of psychological mechanism. I don't know how we objectify that or get it into the general assessment armamentarium, but it seems to me there's an important role for that.
Absolutely. I think, unfortunately, I think if you look at the literature, what you find is that we're not so good at doing self-assessment. So there's kind of a big literature about that, but none of us are really particularly well trained in how to do self-assessment. We don't get the kind of feedback that encourages that. So I think your point's right on, Jordy, in that I think we need to teach people how to do that better in the hopes that kind of reflection, and we have to support them as they do it with feedback that is useful to them. Ultimately, you'd like to get yourself out of the middle and have the provider do it all by themselves.
And George, just to build on that, there's some good work. What we're really looking for is self-directed assessment seeking. So that's Kevin Eva and Glenn Regere's concept. And Joan Sargent talks about informed self-assessment. We're not good if you do it in isolation. If you sit, on your couch and go like, how do I think I'm doing in clinical skills? Yeah, I think I'm pretty good. Doesn't work real well. But informed actually can help people recalibrate, and they can't get better at it if they seek assessment and feedback. That's really the critical element. And I think that's an opportunity for us to think, how do you seek feedback from others that aren't within your discipline or your specialty? And we don't do that very well, and that's a real opportunity. So John, I just want to thank you for really wonderfully setting the stage this morning. So let's give him a round of applause. And so we're going to take a break until 10:30, and then Darla's going to come back and set up small tables so we can take some of this foundational knowledge and this wonderful conversation, and we're going to look at some specific questions about how we can move this forward. So John, thank you again, and we'll regroup here promptly at 10:30. And remember, that clock is 5 minutes slow.